discussion to hear from physician and nurse health system leaders. And so I'm just going to ask the three of you to talk a little bit about your experiences with trust and misinformation, and then maybe have a second round where we can talk about what you're doing to address some of those issues. So Odette, I'll start with you.
When you look at trustworthiness, the first for 25 or 21 years has been nursing, followed by physicians, pharmacists is third. Business executives are at 17%, way down in the bottom, and I would say healthcare leaders and insurance company executives are in that group, and followed by members of Congress, so just digest that, and telemarketers being last. So when you look at the dichotomy of, where healthcare started as a mission, as a service, that's turned into a big business, and you put patients in the middle of all that, and you start thinking about when hospitals and health systems go toe-to-toe in the newspaper because they are not on the same page about what the contracting should be, and you see that patients are trying to figure out what the heck is going to happen to me as far as my health care when I'm with Cigna or United or whatever, you can start seeing the trust issues evolving. It was interesting to listen to some of the stories about how much time physicians have with patients, and we feel that we're improving medicine by putting Epic and other health electronic medical records in place that physicians struggle with. And we're all timing how long a visit should take. And all of those things are contributing to what we see in the industry. I'm a nurse by background, and I think about, the interaction between physicians and patients and nurses and patients. And I think that, the nurse is there with much more time to be empathetic, communicate, focus on what the patient's needing. The physician's there to give that information, and that nurse is to support that physician. And then you get administration and other things to manage the business, and that's where you start seeing the mistrust.
Thanks, Odette. Eric.
Yeah, so I agree with everything that's been said in the previous sessions, and this has been an amazing kind of morning so far. I think a couple of things I would add, just building on some of the comments, is I think it ultimately comes down to a lack of humanism and a lack of caring, ability to care. So talking about burnout, talking about our staff. And what really struck me, I'll tell a couple anecdotes. So I got the privilege to serve as interim CEO of both Elmhurst Hospital when the vaccine was rolled out, and Harlem Hospital when the New York State vaccine mandate for healthcare workers came out. And just the power of your social networks, your families, your friends, compared to like what we've learned in medical education or working in the hospital. What really struck me is our healthcare workers are also from these communities. They are people, they are just as susceptible to misinformation, to social media. And how are we supposed to compete with like what's being said around the dining table or what's being said around the barbecue grill, in the backyard. And so when I was going out and doing my daily rounds as CEO when the vaccine was coming out, I thought for sure Elmhurst Hospital, anybody who lived through those few months will be kicking down the door to get the vaccine. And I had people telling me all the craziest, it's a hoax, it has the herpes virus in it, they're tracking me with this vaccine, the same things you were seeing on Facebook and in the community. And I'm like, how is this possible? You saw the 5 refrigerated trucks in the parking lot, because our morgue was overwhelmed. You lived through COVID. How is this possible? And so that really struck me that if we can't even convince people who are seeing it with their own eyes, how are you going to reach people who don't? And then with the vaccine mandate, so at Harlem Hospital, we were looking at 70% compliance with the vaccine. So we were going to lose 30% of our staff, that had to be laid off if they didn't get it by October, And this was a different one, right? It was mostly Black and brown healthcare workers from a mostly Black and brown community. And their mistrust was the same as their family members, right? And trying to convince people to get the vaccine, not feel like they lost autonomy and choice, was a whole different experience. But even before COVID, when Dr. Mitch Katz, and I and a few people joined New York City Health and Hospitals, there was a lot of mistrust between the employees and the leaders. We work in a part that's called central office. And one of the things that I did is I went to every hospital and asked everybody who would meet with me one-on-one, what's working, what's not working, how can we help, right? And it's felt like decades of mistrust, of things they wanted to tell central office, all these nicknames. My favorite was someone called it the Death Star, right? But it was a bad situation. There was a $1.6 billion structural deficit on a $6.5 billion budget. And they had gone through multiple layers of managerial reductions. They had gone through all these smart consultants that came in and said, you need to close these 2 hospitals, you need to close these services, stop backfilling nurses. Like, how is that ever a good idea? But the staff were operating with mistrust and this black cloud of, is my service the next one that's going to be closed? And so I think, right, the trust between our employees and the leaders, if that's missing, then how do you expect there to be trust for patients and our healthcare workers, right?
Thanks. Yeah, the guy from the central office, that's got to be below Congress on Odette's list there, right? So, David, you have a bit of a different perspective at the Joint Commission. Why don't you tell us what you're experiencing?
So as an accrediting organization, our experience is obviously different than for direct healthcare providers, but I think a lot of the root causes, the misinformation, the causes, the consequences really are similar. So we deal with misinformation all of the time. An organization or an individual will say that we require something when we don't, or they'll say that we prohibit something when we do allow it. And a great example of this, sometimes these just come from sort of a rumor, if you will, or a perceived situation that spirals out of control. The anesthesiologist came to us and they said, why do you require sterilization of laryngoscope blades? And we said, well, we don't. Where did you get this idea? And this organization, little did they know it, but their organization decided they had so many problems with high-level disinfection. They were just sterilizing all of these. And the clinicians, the anesthesiologists were complaining they had to open up these packages, and it really hurt both patient care as well as efficiency. And they realized that this was just because of this story or this practice that had come about and that it spread nationally. Some of the times the intentions are not quite as benign. We frequently see organizations that they have a policy and they want to point the finger at somebody else besides them as they're trying to enforce this. So they'll say, well, the Joint Commission, the Joint Commission requires this. It's like, well, really not so much. But, in both these situations, I think we don't help the situation because we don't make our standards publicly available. So the source of truth is not out there for the clinicians. And I've talked with this for many years now at the Joint Commission about doing that. Maybe this conference can be the impetus for moving that forward, because I think if there is not a clear source of truth, there's distrust, and that's the environment that really allows misinformation to proliferate. And then the last situation is the most frustrating for us is particularly for medical products, devices, even software, that they say that they meet our requirements when they don't. And there was one organization that bought 15 medical beds for a geropsych unit, and they said, well, these are ligature resistant. They meet all the requirements. And we said, no, that's not the case. We don't meet with any drug companies. We don't meet with any device manufacturers just for that reasons, that we don't want to give anybody the impression something that they can spin. So unique challenges, but I think, again, the key is we have to improve transparency and trust.
Thanks, David. So now I'm going to just move to, from what you've observed, to some of the things that you're doing to address issues of trust and misinformation. Eric or Odette, who would like to go first?
So I'll start with the patients. Susan talked about patient advocates. I think many of us have patient advocates. I struggle with that a little bit because they come in when there's already a problem, right? And recovery is important, but when you get to that point of mistrust of what the clinicians are doing or not happening in the care space is an issue. We all have patient advisory councils to be a little bit more proactive in how we manage those relationships and understand proactively what patients are feeling in our organization. And I would say prior to COVID, and we just haven't, I guess we're still all exhausted, we had leaders go and visit inpatients on a regular basis to ask them how their care was going. So that's important in the patient space. With our physicians, as the CEO of the health system, I have a physician advisory council that I meet with on a regular basis to really hear from them. It's my time alone with them, so they don't feel like I'm being influenced by other leaders. They actively assist me in making the agenda. And then for the broader health community, I have what we call the CEO roundtables, where I invite business leaders of the community to come and just meet with me. We talk about what's going on in healthcare to help them understand. We may highlight a very specific service line and have a physician where, sometimes they never get that access to physicians. So I don't think that there's one silver bullet, and I think we're all trying to figure out, with everybody in the state of burnout, moral fatigue, how do we continue to move our initiatives forward? But those are some of the things that we're doing.
What about you, Eric?
Yeah, so some of the concrete things we've done is, I think, getting back to patients might not know if you've read last week's New England Journal article on the most recent randomized control trial and you're doing the most evidence-based, right, treatment for them, but they can all tell whether or not you care, right? When we go to the doctors, we can tell if the doctor is listening to us, if they care about us. I think it's the same with our staff as well. So going back to the example of coming in as a new leadership group of a failing system and having this huge kind of chasm between the employees and the staff, what really struck me is that in our most senior meetings, we were talking about these big things. How do you close a $1.6 billion structural gap? How do you improve quality and safety and transform primary care? But at the same time, our president and CEO, Mitch, had this real open door policy. No matter who you are, you could email the CEO. And so in these meetings, he would bring up, somebody from Bellevue, an anesthesiologist, emailed me and said, they really hate pediatric cases. The kids all cry on the way to the OR. I was like, yeah, it must be really hard to be MPO when you're a kid and you eat every hour when you're awake. They're like, no. We pass a bank of vending machines and they see chips and candy and so they're crying because they're hungry and they see these things, right? And so it's like, well, can we move them, right? And like later that afternoon, it's gone, right? Another topic brought up in our strategic planning, like people were saying it takes 5 minutes to get authorization to make a long distance phone call, right? So imagine a resident, right, trying to get through their checklist. They have to make 5 long distance phone calls. That's half an hour of your day, just like proving that you need to make this phone call. And so we asked the CIO, how many minutes do we have for long distance? It's like, it's an unlimited plan, right? So that changes right away, right? And so that people see that we are actually listening and caring, it became this whole initiative called 100 Small Things That Make a Big Difference. And if they see things that are changing, when traditionally in public systems, people have this learned helplessness, have this, right, things are always going to be county, always going to be H&H, right? Nothing changes here. To see those small changes, they started bringing bigger problems, medium-sized problems, bigger problems, and really engaging them. And the second was, right, you often have new leadership coming in and be like, okay, we got this strategic plan. I'm going to make the staff work harder. They're going to do just culture training, team steps training, We're going to like learn how to code and document and build better, right? But Mitch and I said after our first meetings, no, we're going to come in and bring a program that we built in Los Angeles called Helping Healers Heal. We're going to bring emotional and psychological support to the staff that are even more traumatized than the previous staff that we worked with in Los Angeles. And so those two things really start building that trust. And the whole idea is, right, J.W. Marriott's quote, you take care of your employees, the employees take care of the customers, the business will take care of itself. Even more important in healthcare, everything's about human connection. We need to have full tanks of empathy, right, and be well to be able to give that to the patients. The patients can tell. If you're burnt out, patients can tell. They know that you're not listening and that you're not caring. And that just continues to feed the mistrust. And then the last one I'll share was actually an honorable mention in the medical student essay contest that we just heard from Dr. Chris Montgomery, UCSF medical student who's now an intern at UCLA Emergency Medicine. He did a gap year. He did a year and a half with us at New York City Health and Hospitals, and he came in with all these big ideas, right? How do we get humanism back into the electronic medical record, right? It's humanistic charting initiative. But another one was about a community activation model around COVID vaccine uptake. And his initial dream was to work with the Department of Education to, at a 6th grade level, teach kids the basics about what is a virus, right? What is your immune response? How do vaccines work? So hopefully they can go back at the dining table and educate their families. That didn't work out, but he also came with me to Harlem Hospital during my stint there, and we were staying at this 30% unvaccinated. And so he took the workshop that he created that he was going to teach kids and met with every single unvaccinated Harlem employee, in groups of 1-on-1 to 5 to 10. He kind of became de facto mayor of Harlem because everybody knew him. But through, a more kind of trustworthy, credible messenger than the CEO or the boogeyman from central office telling you that you must get vaccinated, right? Here's a medical student who came from the community speaking to them without titles. And he convinced many of them to get the vaccine before the mandate. And certainly those who did only to save their jobs felt better about getting the vaccine. So using a community activation model to try to get to those conversations around the dining table at the family barbecues.
Well, I'm hearing a theme of time and listening, and there's sort of no substitute for taking some time, huh? David, what about at the Joint Commission?
So that story that I told before about anesthesiology led to a really great experience working with the American Society of Anesthesiologists. They put out a questionnaire to their members about what were these things that the Joint Commission had that were most problematic, and we went through those. And then we came up with a list of responses to those, explanations, true, false, etc., and gave the information to them to distribute to their members. Because obviously, who's the trusted source for an anesthesiologist? It's going to be their society, right? So working with them was a great partnership. But the other thing that made a big difference in the trust was for one of these, when we looked this up, it really was not evidence-based. And we ended up actually changing the standard. So that's, when we talk about cultural humility, before that, there's just plain old humility. And being able to be honest and say, gosh, you're right. So that's been very helpful. We have told our staff, or at least I've told my staff, if an organization comes to you with a concern, there are only 3 options of what to say. 1, you're right and we'll change it. 2, we don't think you're right and this is the reason that we're going to not change it. And 3rd, you're right, but we can't change it because that's in federal legislation or something, but we'll advocate on your behalf. And I think that's helped gain trust as well. The other thing that was a big issue during COVID was, again, the lack of that source of truth. Some of you may have been involved. There were waivers from CMS. Things were changing by the day. So we actually started doing weekly sort of town halls, getting out frequently asked questions, et cetera, but then just allowing, for the first time, really people to have these open forums because it was just so overwhelming. We'd like to be able to continue that. I think that openness, again, transparency is the best way to build trust.